Aneurysm is pathological dilation of vessel wall and it is classified in various ways. We have whether the aneurysm is true or false. See, vessel wall has various layers. So there is tunica intima, tunica media and tunica adventitia. When there is dilation of all the three layers of the vessel wall, it is known as true aneurysm. In false aneurysm, there is disruption of the tunica intima and tunica media, and blood may flow out into the space. And what happens that the dilated segment is lined by adventitia. So this is lined by the adventitia, or it may flow out completely. Even adventitia may be disrupted, and blood may be here, and a clot may form. So in that case, it is covered by a perivascular clot. So in this case, there is no dilation as such of the layers. Understanding the layers have been disrupted and the blood has gone out. This is appearing as a dilation. So this is a false aneurysm. We will be talking about the true aneurysm. So second way of classification of aneurysm is based on its gross appearance, whether it is fusiform or saccular. Fusiform is when it is involving the vessel wall circumferentially. That means 360 degrees it is involving the vessel wall. That is fusiform aneurysm. Saccular aneurysm is that involves only a part of a circumference. Okay, so this appears similar to that of the false, but here see, I have not drawn any disruption of the vessel wall. It is only a dilatation of the vessel wall, but only a part of the vessel wall. Okay, so this is saccular aneurysm. Now, causes of this fusiform and saccular aneurysm vary. For example, atherosclerosis. Atherosclerosis is an eccentric lesion, that is, it is involving only a part of the vessel wall. So, that leads to aneurysm. So, obviously, the aneurysm which occurs due to atherosclerosis will be saccular. Then, mycotic aneurysms, if there is infection of the vessel wall. So, maybe the infection is affecting only a part of the vessel wall. So, that also will be saccular aneurysm. On the other hand, hypertension. Hypertension causes fusiform aneurysm because hypertension aneurysm is happening because of increased tension on the vessel wall. There is hemodynamic disturbances. So in that case, they will be affecting throughout the whole circumference of the vessel wall. So that will be fusiform aneurysm. Then if there are any genetic or developmental disorders, that will also lead to fusiform aneurysm because genetic or developmental diseases will affect the vessel wall components, that is collagen, circumferentially. Okay, so that will also be fusiform aneurysm. Then third classification is based on location. These aneurysms generally we see in aorta. So we have a thoracic aortic aneurysm or abdominal aortic aneurysm. There can be involvement of other vessels as well, but we will limit to the involvement of aorta. Okay. Now, before we understand the pathogenesis of aneurysm, little bit we should know the layers of the vessel wall. So, vessel wall, as I told you before, consists of three layers. There is tunica intima, then there is tunica media, and there is tunica adventitia. And here is the lumen of the vessel. So, tunica intima is the innermost layer and it consists of a single layer of endothelial cells which is supported by a extracellular matrix layer that is also known as basal lamina. So, this extracellular matrix, as the name suggests, it will consist of collagen. Then there is subendothelial layer which may be present in some vessels, may not be present in other vessels. Subendothelial layer again consists of smooth muscle cells, collagen and elastin. Coming to tunica media is the contractile layer. It consists of smooth muscle cells and also has elastic fibers. Then we have the tunica adventitia. Tunica adventitia consists of collagen and this collagen is important to increase the tensile strength of the vessel. So we are talking about aorta. It will increase the tensile strength of aorta, and there is too much pulsatile flow in the aorta because every time there is systole diastole, the pulsatile flow in the aorta is too much. So because of this tensile strength only, there is ability to accommodate this pulsatile strength, and also elastic lamella are important. See, collagen gives a tensile strength and elastic lamella has elastin. If we see subendothelial layer also has elastin. Actually, this elastin acts like a rubber. It will stretch and come back to its position. So elastin and collagen are very important for maintaining the function of the vessel, for providing the tensile strength, that is the collagen, and also to accommodate the pulsatile stretch. Now, tunica intima is separated from tunica media by internal elastic membrane, and tunica media is separated from tunica adventitia by external elastic membrane. So they also have elastin. Okay, so these are the layers of the vessel wall. Why are we talking here in terms of aneurysm? Because in aneurysm, it is the destruction of this elastin and collagen fibers. So what will happen? If they are not synthesized properly or there is increased destruction, then the tensile strength of the vessel is going to decrease, and hence it will not be able to accommodate the pulsatile flow. And because of the hemodynamic stretch, because of the blood flow, the stretch which is happening, it will cause a dilation of the vessel wall. So yes, for pathogenesis, either there is problem in the collagen production, either there is inadequate production or decreased collagen production, or there is increased destruction of collagen and elastin. Okay. So smooth muscle cells, which we have talked, they are responsible for the production of collagen. This we have seen in the video on atherosclerosis also, that smooth muscle cells are synthesizing collagen and they are responsible for the fibrous cap of the atherosclerosis. So yes, smooth muscle cells produce the collagen. So if there is decreased collagen production, the wall strength is going to decrease. This occurs in increased TGF-beta signaling. For example, in Marfan syndrome. In Marfan syndrome, there is lack of fibrillin 1. Actually, there is decrease in elastin production, we can say, not in collagen. Both are important, collagen and elastin. And this fibrillin 1 is important for the cross-linking of the elastin which is produced. Okay, so fibrillin 1 is a scaffolding protein for the elastin. In Marfan syndrome, there is lack of fibrillin 1. And TGF-beta signaling, actually why I have written, because this TGF-beta keeps the smooth muscle cells quiescent. Smooth muscle cells are quiescent. That means they are not going to produce collagen and elastin. So if there is increase in TGF-beta signaling, then it will lead to decreased collagen production. Then there is a genetic disease, Ehlers-Danlos syndrome, in which there is defective type 3 collagen synthesis. Type 3 collagen is the collagen which is present in the blood vessels. How I remember this is type 3 is equal to tree and blood vessels divide like a tree. Okay, so this is how I remember. Type 3 collagen is present in the blood vessels, and in Ehlers-Danlos syndrome again there will be vascular malformations because of defective collagen 3 synthesis. Then increased collagen destruction can happen if there is increased production of matrix metalloproteinases by the macrophages. This again we have seen in atherosclerosis, how macrophages are responsible for increased MMP production. So yes, atherosclerosis, hypertension, aging, male gender, increased cholesterol, oxidative stress, vasculitis, all these are causing increased MMP production. So atherosclerosis, basically the local accumulation of the macrophages, that is going to produce MMP. Hypertension, again because of too much hemodynamic disturbances. Vasculitis, oxidative stress, so any kind of inflammation leads to increased MMP production. Okay. Decrease in TIMP production. TIMP is tissue inhibitors of matrix metalloproteinases. Okay. Tissue inhibitors of metalloproteinases. So if their production is decreased, then also there will be increased destruction, because in that case there will be increased MMP action, right? Normally TIMP is going to inhibit the matrix metalloproteinases. If TIMP is not being produced, an increased action of MMP will be there. Then ischemia of the vessel wall, as again we saw in atherosclerosis. So understanding collagen elastin production if it is decreased, collagen elastin degradation if it is increased. So both are the causes of development of aneurysm. Then there may be loss of smooth muscle cells as well, and there may be change in SMC phenotype. So loss in smooth muscle cells, since they are responsible for collagen production, collagen will not be produced. Change in phenotype, that means the amount of collagen which is produced may be less, right? Now, before we proceed to the causes, just one important thing I want to discuss here, that the pathological change which is seen in aneurysmal dilation is known as cystic medial degeneration. Cystic medial degeneration. Actually, there is nothing cystic about it. It is the degeneration of the tunica media. So, there is loss of the smooth muscle cells. There is degeneration of the collagen, elastin in the tunica media. And in turn, the tunica media cells are replaced by clefts of mucoid material, that is proteoglycans. Proteoglycans, okay. So collagen, elastin, smooth muscle cells are going to decrease. There will be accumulation of proteoglycans. This is the pathological change which is seen. Now moving on to causes of aortic aneurysm. So I told you that it is classified based on the location of the aneurysm as thoracic aortic aneurysm and abdominal aortic aneurysm. So there are different causes for these as well. Here a diagram is shown of the aorta to make you better understand. First is the causes for the ascending aorta and aortic arch. Ascending aorta, most common causes are syphilis and inflammatory diseases like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis. I told you that if there is inflammation also, that can cause the destruction of the collagen and elastin, right? Then aortic arch, mostly in syphilis. So syphilis can affect ascending aorta. Ascending aorta, the time the aorta is rising from the ventricles, it can affect the aortic arch as well. And the causes are vasculitis, that is Takayasu arthritis, giant cell arthritis. Then thoracic aorta. Thoracic aorta causes are atherosclerosis, hypertension, chest trauma, and tuberculosis. Tuberculosis affects thoracic aorta because there may be tubercular infection of the lungs, and direct extension of the infection from the hilar lymph nodes can involve the descending thoracic aorta. So just the proximity of the infection with the descending thoracic aorta and this tubercular infection may extend into the thoracic aorta, and then there will be granulomatous destruction of the medial layer of the thoracic aorta, right? Then abdominal. Most common cause is atherosclerosis and the location is mostly below renal arteries. So here I have shown some branches of the abdominal aorta. There is superior mesenteric artery, renal arteries and inferior mesenteric artery. Renal arteries arise between L1 and L2. See, abdominal aorta is present between T12 and L4, okay, and renal arteries arise between L1 and L2. So mostly below that region we have this aortic aneurysm which is occurring due to the atherosclerosis. Now moving on to consequences, that what is going to happen, how these aneurysms are detected and what are the problems which may occur, right? So first of all, most of the aneurysms can be asymptomatic when small, okay, and they are incidentally detected on chest x-ray in case of thoracic aortic aneurysm, or with USG abdomen in case of abdominal aortic aneurysm. So that is one. It can be asymptomatic. If it is detected, then in that case, depending on the size, we have to decide for the treatment. If the size is very small, then monitoring every 6 to 12 months can be recommended. And if the size is larger, then surgery can be advised. So that is one. Then there are chances of rupture because now the vessel wall has dilated. So the tensile strength of the vessel is lesser. It is not able to accommodate the pulsatile stretch. In fact, with time, there is increase in the expansion of the aortic aneurysm. Why? See, there is a theorem known as Bernoulli's theorem. Bernoulli's theorem, right? Bernoulli's theorem says that the total energy of the moving blood is constant. So we can say that the energy, that is the kinetic energy due to the moving blood, and potential energy, which is basically the pressure which is being exerted on the vessel wall, if we keep it is constant. Okay. Now at the site of the aneurysm, what will happen? That kinetic energy is going to decrease because this is a dilated area. So that means the radius has increased, and whenever radius increases, velocity there decreases. Understanding? So whenever radius increases, velocity decreases. So we know that velocity is equal to flow upon area. Okay, flow upon area. When area increases, when there is increase in radius, whenever radius will increase, area is going to increase. So if area increases, velocity is going to decrease because flow is going to be constant. The amount of blood which is passing a particular area, it is going to be constant. So flow is constant. When area increases, velocity decreases. Fine. So kinetic energy, it is going to decrease. But because the sum of kinetic energy and potential energy is constant, so when kinetic energy decreases, potential energy increases. So that means the lateral pressure which is being exerted on the vessel wall, that is going to increase. Understanding? So one is forward energy and one is this lateral pressure. Total energy is constant. Okay. So forward we are telling about kinetic energy because of the flow, and then there is pressure exerted on the vessel wall. So when this forward energy decreases, pressure exerted increases. Now, we have already told that there is destruction of the collagen, or the collagen amount is less in the vessel wall. So, if there is lateral push on the vessel wall, then there will be chances of more dilation of vessel wall. Understanding? So, hardly if aneurysm forms, it stays in that way. It expands with time. So, it is important that it is monitored with time. That is one thing. Then Laplace law explains that why there are chances of rupture. Laplace law says P is equal to 2T by R. So 2T, that is the tension on the vessel wall, is equal to pressure into R. If radius increases, then with the same pressure only, with the same pressure, tension on the wall is increasing. Okay, so here there is more tension on the wall with the same pressure. And what we are telling here, in fact, the lateral pressure is increasing. Okay, understanding? So yes, with radius increase, tension on the wall increases, and according to Bernoulli's theorem, pressure on the wall is increasing. So wall tension is increasing too much. So that means there are high chances of rupture, right? And remember that aneurysmal pain is a harbinger of rupture, and it is treated as an emergency. So that is second, very important emergency condition, right? So it can be asymptomatic, but then it has to be monitored. There can be rupture of the aneurysm. Then there are other problems which may occur depending on the site of the aneurysm. So in case the site is ascending aorta, then there may be development of aortic regurgitation because there is dilation here. So maybe the aortic valves will also be involved. So there will be increased space between the aortic valves because of the dilation. So aortic regurgitation can occur, and this will lead to congestive heart failure. Okay. Then it can also lead to compression of the superior vena cava and hence lead to congestion of head, neck and upper extremities. Then there may be narrowing of coronary ostia. Actually, whenever the aneurysm develops, because of stagnation also, we have seen that there is decrease in the velocity. Because of stagnation, there is development of mural thrombi. Okay. So within the lumen, there is development of thrombi. And this thrombi, when it extends, it will extend into the opening of the vessel. So there may be narrowing of the coronary ostia. Coronary vessels are arising from the beginning of the ascending aorta itself. Okay, there are aortic sinuses, dilations are there from which coronary vessels are arising. So they may be blocked. This will lead to decrease in blood vessel, and ultimately it can cause myocardial infarction. So that is ascending aorta. Then in case of descending thoracic aorta, you see that descending thoracic aorta is related to various structures. This is esophagus, okay, and here this is trachea, this is the left bronchus, and this is the right bronchus. So depending on which structure is involved, there might be symptoms. So yes, it may be asymptomatic, there may be rupture, but apart from that, there may be other symptoms as well because of compression of adjacent tissue. So if there is involvement of trachea or the left bronchus, then it will cause breathing difficulties and cough. If there is compression of the esophagus, then it will lead to dysphagia, that is swallowing difficulty. If there is irritation of recurrent laryngeal nerve, it will lead to hoarseness. Then behind the aorta, okay, posterior relations of the aorta, we have the vertebra. So vertebral erosion can also occur, leading to back pain. And because of expansion of the aortic aneurysm, there may be compression of the mediastinal structures as well. That will lead to chest pain, right? So these are the various problems which can occur in case of thoracic aneurysm. Moving on to abdominal aneurysm. Abdominal aneurysm again can be asymptomatic, can rupture, or it can be felt as palpable, pulsatile, expansile, non-tender mass. So expanding mass which is pulsating because it is the blood flow, right? So that mass can be felt. So that is one thing. Then the mural thrombi which develops in case of abdominal aortic aneurysm, it can block the various vessels which are coming out of the abdominal aorta, right? So here the branches are shown. So you see this is superior mesenteric artery which is coming out at the region of L1. We have renal artery coming out between L1 and L2. Inferior mesenteric artery and gonadal arteries come out at the level of L3. So they can be blocked. Okay, so block of superior mesenteric, inferior mesenteric artery can lead to GI ischemia. So there will be abdominal pain. Block of renal artery will lead to renal ischemia, leading to renal failure ultimately. Block of iliac arteries will lead to leg pain. So sorry, here I have written, it should be here. Block of iliac artery will lead to leg ischemia, leg pain. Iliac arteries. See, ultimately the abdominal aorta is dividing into common iliac arteries at the level of the L4. So if the aneurysm extends here and there is block by the mural thrombi, it will lead to leg ischemia. Then these iliac arteries are also associated with ureter. Okay, so anteriorly the relation is ureter. So ureter compression can also be there. And behind, just like thoracic aorta, the posterior relation of the abdominal aorta is vertebra. So that also can happen, erosion of the vertebral bone. So depending on where the aneurysm is developing, we can have the various features. Then little bit we will talk about treatment. See, if thoracic aneurysm is more than 4 cm or abdominal aneurysm is more than 5 cm, then surgery is recommended. Because once the aneurysm is of this size, then there are high chances of rupture, okay? And the mortality rate increases. If the rupture happens and the person is taken for emergency surgery, then there are high chances of mortality, okay? So in these cases, either a bypass surgery can be done or stent grafting. Nowadays, stent grafting is preferred, okay? So stent is inserted in the area. For lesser size, monitoring every 6 to 12 months is recommended, and if the rate of expansion of the aneurysm is high, then again the surgery is recommended. For male people who have ever smoked, ultrasound screening is recommended for the age group of 65 to 75 years of age, because smoking is one of the main risk factor for development of atherosclerosis and aneurysm. So for this age group, ultrasound screening is recommended for the detection of aneurysm. So that was all about aortic aneurysms. Thanks for watching the video. If you liked it, do press the like button, do share the video with your friends, and don't forget to subscribe to the channel Physiology Open. Thank you.